Welcome to this OncLive News Network presentation, broadcasting live from MJH Studios. Today's discussion will be focused on recent advances in treating follicular lymphoma. I'm your host, Dr. Bruce Cheson, Professor of Medicine, Head of Hematology and Cellular Therapy at the Georgetown University Hospital Lombardi Comprehensive Cancer Center in Washington, D.C. Today I am joined by two of my colleagues and friends who are renowned experts in the treatment of lymphoma.
I am Dr. Younes, Chief of Lymphoma Service at Memorial Sloan Kettering Cancer Center, and happy to be here.
And I'm Nathan Fowler, Associate Professor of Medicine at the University of Texas MD Anderson Cancer Center in Houston.
We're going to spend the next 60 minutes talking about an area that has seen significant progress recently, the treatment of follicular lymphoma. We'll discuss how the latest data from clinical trials are shaping the way you will treat your patients. At the end of the program, we will open the discussion to answer questions that were submitted to OncLive in advance from our viewers. Now, what we've all seen since we treat a lot of follicular lymphoma is that not all patients are created equal. They seem to show up with similar clinical features and have remarkably different outcomes. There have been a number of attempts to develop prognostic scores to separate these patients into clinically meaningful groups that we approach differently with regard to our therapy. Have we really accomplished that?
It's tough. I think when patients first present to your clinic, we do the typical things. We do staging and we figure out what the grade of the lymphoma is. And then we often have a kind of a discussion about what are the first steps in managing the patient. As you mentioned, because many patients present differently and they can have this very different outcomes with the same therapy, it's a little bit difficult. So I often do use some of the new scoring systems, Flippy2 and Flippy, and these are systems that look at patients' pre-treatment patient characteristics, things like their age, their stage, LDH, et cetera, and it can kind of give us a sense of how patients might do in the long term. Ultimately, I don't necessarily base treatment decisions on those different scoring systems, but it does kind of give me a kind of a gestalt about how these patients are going to do over the long term.
Younes, what about the more molecular prognostic systems like the M7 Flippy?
Right, so the M7 Flippy system uses 7 gene signature to predict the outcome of patients treated with frontline regimens. Unfortunately, it doesn't guide therapy. It doesn't tell us how to treat these patients, just tell us about long-term outcome. But we don't have a prognostic factor model right now based on genetics or biologic features that would guide therapy at the present time.
Yeah, so we treat our patients based on how we treat our patients, not on any of these scoring systems. But after treatment, something strange happens. You've got two basic groups of patients. You've got those who have an event within 1 year or 2 years or 30 months, and they do great if they don't. And if they do, they do very poorly. How can you approach that observation in management of these patients?
That's tough. And what you're referring to, obviously, Bruce, is this data that has come out fairly recently looking at patients that progress early after frontline therapy. And we now have there's several groups that have presented data showing that patients that progress after CHOP, as well as some of the other newer combined chemoimmunotherapy regimens, tend to do worse if they progress early. A lot like the Flippy scoring system and the M7 Flippy, although we have this data, I don't think it's really clear how we're going to use this data. What I mean by that is, although these patients tend to do worse, it's unclear whether changing intervention when they relapse is going to change that outcome, right? So it may be that these patients, unfortunately, have certain biological characteristics which are going to portend a poor prognosis, and that will still be poor even with newer agents. Now, I think all of us hope that that's not the truth. And there are a lot of newer trials coming out where we're looking at using novel agents for these patients that progress early. But at least today, I think if I have a patient who progresses within the first 2 years, I still kind of go through the same decision process, and that means picking another chemotherapy which is different than their first line.
Well, but you're saying we got to wait 2 years and see what happens.
Right.
We have a number of ways to predict outcome earlier, such as PET scans, such as MRD. Do you use those to judge and guide how you manage your patients?
So MRD first is really not used in clinical practice outside clinical research to guide therapy. So we are incorporating multiple different assays to measure circulating tumor DNA and call it MRD in the setup of different treatment strategies. But we're not acting on it yet. We're just collecting this information. The PET, again, PET is after the event. You already started therapy, so whether you're talking about interim PET or end of therapy PET, yes, they can tell you how the disease will behave, but you're still not picking up these patients up front. So yes, we'd use PET, and it's a very good tool to tell you what the outcome is going to be, but we need some tools or algorithms or guidelines to pick up these patients up front and offer them different therapy if possible.
There's been an observation by Michel Mignon's coworkers of combining total metabolic tumor volume with the FLIPP2 before treatment. You can separate patients into 3 distinct groups. Is that ready for prime time?
I don't think it's ready yet for prime time. The data need to be confirmed, need to be transferable to an average community oncologist to know how to deal with it, interpret it, and then and use it. Right now, I think it's a great observation. I think it's a good research tool. Whether this will become as part of a standard practice, it's yet to be determined, I think.
Did you want to make any more comments?
No, I think, I mean, I totally agree with Younes, and one of the problems I have with a lot of the scoring systems, whether that's using M7 FLIPPy or total metabolic volume, or the FLIPPy score, the API, is that they only predict how a group of patients will do. And if you look at individual patients within that, for example, individual patients that are in the M7 FLIPPy, a significant portion of them will actually do great and do great long term. So when I'm faced with talking to a patient about this scoring system, I always like, especially patients that have a poor score, I like to remind them that this is not universal, and some patients will do well even with these scoring systems. And again, why that's relevant is when we're thinking about how to design next line regimens and maybe put patients in different buckets, at least with the scoring systems we have today, because they're not universal, I have a hard time picking treatment or putting patients in a certain trial based upon that score, but based upon the available scoring systems.
Yeah, I think we kind of all agree that that's right now the holy grail is predicting patients up front,
Right.
not groups, but individual patients, and stratifying them based on some sort of biomarker as to what kind of therapy they'd respond to versus another.